There are roughly 70 hospitals with emergency rooms in Massachusetts, serving a population of 6.8 million people. The hospitals vary in size, location, ownership status, and diversity. Some towns are more represented than others. For example, 107 Massachusetts cities or towns have no primary care physicians. What many of these hospitals have in common is that their emergency departments are overfilling and overcrowding with patients, and yet many of these hospitals are reporting nurse and doctor shortages. This map of the average wait time in U.S. cities represents this phenomenon. Boston displays the highest wait times of the selected cities for scheduling appointments with providers of various specialties.
Mr. Russell, can you tell me what's causing you pain?
I think it's my stomach.
Have you been experiencing pain for some time?
My whole adult life. I have a history of ulcers, but feels like something's not right this time. I tried to get an appointment with my doctor, but he didn't have any available for a few weeks. So when things didn't feel right, I decided to go to the ER.
How long was the wait?
6 weeks.
I'm sorry to hear that, but we're gonna figure out what's wrong and get you feeling better. I want to do a workup to make sure it's nothing heart-related.
Mr. Russell? Mr. Russell, are you okay? Nurse, we've got a patient crashing. I'm going to need some help here. Let's move him to critical care 3.
Hi, I'm Dr. Mike Evans, and welcome to the Emergency Department, or the ED. So it's a busy place with people of different ages and an incredible mix of injuries and illnesses. But there's one question probably everyone here asks themselves. Why am I waiting? Great question. So I think the first thing is to step back a bit and consider the physical emergency department is actually interconnected with a much larger web of people and services right around the whole hospital and sometimes beyond. From the highly specialized ED nurses in charge of assessing patients and keeping everything organized on the front lines, to the doctors, on-call experts in surgery, obstetrics, general medicine, cardiac care, and so on, to networks of testing services like labs, radiology, and imaging technicians. All these moving parts work in your favor if your problem is complicated or urgent, but it also means there are a lot of places where care may take more time and slow down, such as a lineup for the CT scan. And this can lead to waiting. Emergency departments are carefully staffed with more docs and nurses when we know there'll be more patients. But even so, like at a busy restaurant, when it's full, the waiting will be longer. The second concept, and this is key, is that unlike your local walk-in, the emergency department is not a first-come, first-served place. ED staff have to decide who needs medical attention the most urgently, and they do this using a process called triage.
Now let's try to analyze what this shortage means. The shortages can result in longer wait times at urban teaching hospitals and an increase in chronic diseases for the aging population. On top of this, the overall distribution of doctors results in some areas having too many, while other areas suffer from having too little. We have also seen a trend indicating a greater focus on specialization with a simultaneous decrease in generalists. With this situation, we will need to rely more on mid-level practitioners such as registered nurses and physician assistants. One of the most glaring problems with regards to hospital shortages deals with the lack of nurses. The Massachusetts Hospital Association and the Organization of Nurse Leaders reports a vacancy rate increase for registered nurses from 3% in 2010 to 3.9% in 2011. These vacancies are highest amongst emergency departments. Nurse burnout leads to a higher healthcare associated infection rate and costs millions of additional dollars annually, according to a study published in the August 2011 issue of the American Journal of Infection Control. The number of U.S. emergency rooms has dropped by more than 25% in the past 2 decades, but patient visits have continued to rise. Most experts agree that the resulting ER overcrowding has reached crisis proportions. An emergency department is considered crowded when inadequate resources lead to a reduction in the quality of care. These times represent the wait time to be seen by a physician. The national average ER wait times can vary for urban versus non-urban populations by over 20 minutes. Given that 50% of emergency rooms are operating at above capacity, ambulance diversion also poses a problem with patient care in ERs. Patients needing attention from physicians will often be transported to other medical facilities that are farther away when a given hospital is facing overcrowding. Emergency departments triage incoming patients to manage the constant flow of new cases. This graph displays the categories that patients seeking treatment in the ER fall into. An overwhelming majority of patients are considered to be urgent or less urgent, while smaller percentages come in for emergent and non-urgent conditions. Overcrowding in the ER compromises quality of care and patient satisfaction, drives up healthcare costs and wait times, and threatens community trust. The top causes of ER overcrowding are a lack of inpatient hospital beds, resulting in patient boarding in the ER, and a lack of access to primary care physicians. It's projected that by 2020, the U.S. physician shortage will increase to more than 45,000 primary care physicians. Although annual demand for ER treatment has increased by 34%, there was a simultaneous 11% decline in ERs available to patients. The negative consequences of ER overcrowding include a 5% increase in the risk of patients dying before being discharged from an overcrowded ER. Boarding critically ill patients in the emergency room can also cause treatment delay and poor health outcomes. ER overcrowding even threatens the ability to treat mass casualty victims in a disease scenario. In addition to patient risks, overcrowding results in added costs. According to the New England Healthcare Institute, $38 billion is spent due to ER overuse. $1,086 of revenue is lost from each hour of ambulance diversion, and between $9,693 and $13,298 of additional daily revenue is lost from each hour of ER boarding. Possible solutions to overcrowding include reduced patient boarding in the ER, increased primary care access, reduced processing time for non-critical patients, improved communication between ER and inpatient units, use of online wait clocks and hotlines so that patients can check ER wait times or get health questions answered before visiting, and moving patients from the ER to an observation unit for additional testing and monitoring before being admitted or released.
The emergency room at Social Hospital is one of the busiest in the state. It actually is the fourth busiest in the state, with about 90,000 patient visits per year. Social Hospital is an officially designated trauma center, and about 20% of those visits are trauma related. There are times of the year that the emergency room is very busy. That usually tends to be summer, around holidays, nights. In addition, there are times also that the emergency room is not busy, and that can be at the beginning of a storm or if weather is not really very friendly, or if there is some sort of event, i.e. a Super Bowl. Believe it or not, we often see that there is a window where no one shows up, and then once the game is over, then people start to come over. There is no doubt that the way the medical system has been changing the last 10 years, there has been overcrowding in every aspect of it. There's been overcrowding in physician offices. There's been overcrowding in emergency rooms as well. Patients are often using the emergency room as a PCP's office, and that has definitely made the life of every emergency room very difficult. The result of overcrowding has been the creation of stretchers in hallways that we see in any and every emergency room in the state and in other states, in order to deal with this overflow of patients in an efficient way. I have to admit that this seems to have been very well organized at Social Hospital. The stretchers are designated, coded, numbered, and so that errors in identification of patients and treatment has been minimized or eradicated, period. I come from Greece originally, and I left Greece in 1991, where stretchers were present in every hallway of the emergency room, but as well as in regular floors, internal medicine floors, surgery floors, and so forth. But this was done in a haphazard way and was leading to a lot of errors in medical practice that seem to have been eradicated under the current system.
32-year-old Fatima Ismail knew she wanted to be a doctor as a young girl growing up in Dubai.
I was always fascinated with the brain and how it functions, and I love working with children. And there is a huge population of children with developmental disabilities that are not taken care of very well in Middle East in general and my home country in particular.
So, after completing medical school in her home country, she applied for a training residency at Johns Hopkins University in Baltimore, where she had been an exchange student during medical school. Fatima is one of a select group of international students who is advancing her medical education in the U.S. Her peers have told her how they applied to dozens of programs.
Fatima is one of many foreign-born and trained licensed physicians. Approximately 26% of licensed physicians in the U.S. are foreign-born. They apply to residency programs, most of which are hard to get into.
School administrators suggest that international students apply for residencies after completing medical school in their home countries or to come as an undergraduate. But even the most qualified applicant faces a highly competitive and very expensive road to becoming a doctor in the U.S.
The phenomenon of foreign-born doctors and medical students experiencing difficulty upon entering the U.S. medical field is not new. Residency programs have been, and continue to be, increasingly difficult to get into. However, coupling this fact with the shortage of physicians and nurses the U.S. has been experiencing, we see that foreign-born doctors are possibly the solution to fill this void. As a result of the increasing difficulty for foreign-born medical students to complete residency programs in U.S. hospitals, fewer foreign graduates are applying to these programs. A quote from one doctor gives us something to think about when considering the benefits of hiring and supporting foreign-born medical doctors. Dr. John Henning Schumann is an internal medicine doctor and serves as president of the University of Oklahoma's Tulsa campus. Dr. Schumann is quoted as saying, "Throughout my medical career, I've benefited greatly from working with doctors from other nations. Regardless of their country of origin, doctors who come to the U.S. to train and work are ambassadors of humane values, learning the mores of American culture while sharing their skills and knowledge. A recent study even suggests that patients do slightly better when treated by doctors born and educated outside of the United States. I see this as a win-win. Highly skilled foreigners move along the pathway to becoming permanent residents or U.S. citizens, and areas with a shortage of health professionals get doctors willing to apply their trade and become members of the community."
I need a doctor, call me a doctor. I need a doctor to bring me